welcome to a new episode of Retina Chats. I'm Mohammed Ghunaim, and with me Dr. Mustafa Al-Manhari.
Hello, everyone.
So today's case, this is my case. It's a 50-year-old patient presenting with PDR in one eye and tractional retinal detachment involving the macula in the other eye. So with this picture, what would you tell the patient? Would you go for surgery right away? How would you counsel? Would you inject preoperatively?
No, I will not inject preoperatively, and I will explain that there's a need for the surgery because of this traction and compromising the macula.
Okay.
And there is a high risk of postoperative hemorrhage, probably around 80%. Some of them will resolve spontaneously, some of them may need a vitreous wash. And considering the tamponade, there is a possibility if there are multiple tears, I may use silicone oil. Yeah, despite that, I don't prefer silicone in laser diabetics, and especially when we have these hypoperfused retina.
Yeah, so I injected this patient anti-VEGF 2 days before surgery because there was a lot. This membrane, you can see it's very vascular now, but it was a lot more vascular before the injection, the preoperative injection. So I decided to go for a preoperative anti-VEGF injection 2 days before surgery to try to make the surgery easier and to decrease the possibility of intraoperative bleeding. You can see here that I attacked this membrane from peripheral to central. I started to do PVD in the peripheral attached retina, and then 360 around the membrane before attacking the membrane itself. Okay, next question. Do you believe that would you start with a bimanual surgery from start in this case? No. I know you're not a bimanual fan. I'm not too a bimanual fan.
But in such a case, I'm a big fan of the 25 gauge cutter. It's a game changer in diabetics, especially the 10K. And
Okay.
you are lucky in such a case that the epicenters are bulky and they are away from each other. But if this membrane is broadly attached to the retina, the 23 cutter,
Will not go inside.
especially with low cut rate, it may cause multiple iatrogenic breaks.
I'll show you that it will be difficult with the 25 gauge, but later in the surgery. Okay, in the last step. Okay, so yeah, I believe 25 gauge is important, and it has a lot of advantages in tractional retinal attachment. I use it, but not that common. My routine is a 23 gauge. Would you use scissors in this case, like I'm doing? I love using scissors unimanually. I don't use them bimanually that often, and it highlights a point that you just said that it makes it goes through the space between epicenters without using in these spaces which are very tight for the cutter to go in. It can go in and dissect the membranes. So yeah, I believe that when you have a higher gauge and a smaller gauge instruments, you can go through tighter spaces and dissect.
It acts like a pick and a cutter.
Yeah.
So you can move easily under the membrane if you are in the right plane.
Yes. So let's talk about finding the right plane in these cases. Would you agree on going peripheral to center or just start attacking the membrane?
Yes, I think going from outside in is better in diabetics if you can access the right plane, because sometimes you cannot find it from outside as the vitreous is very adherent to the retina, especially in laser PDRs.
Okay.
So sometimes you may be forced to start over the macula and try to find the plane over using a pick over the disc, because it's the most safe part.
So your preference is outside in,
yes.
if possible. If not possible, you go inside out.
Yeah.
Okay. This is also my preference, but sometimes you can see there is a clear plane in the center. In these cases, I just go with the easier option and start peripheral.
Sure.
Okay, so here I'm dissecting the membrane over a very avascular area, and I'm very cautious to do any breaks. But I'm just going step by step with the scissor to dissect as much as possible and trying to not create any iatrogenic breaks. Here in the area over the macular area, would you shift to peeling technique with a forceps, or
No, I
again
will keep
continue with the
going. I
lamination?
At this point I will use the cutter to remove this dissected area. So yes, as you have just
The
shifted,
problem that the
it's very
membrane
dense. I
very
know.
dense, yeah,
It's
and I will show
like
you at the end of the case that it's not easy to
yeah, it's a cartilage like. It is
yes.
not a usual diabetic membrane. Yes.
Okay, so yes, I went in with the cutter, and now I'll just fast forward a little bit. Here I dissected the membrane from the inferior part, and with the cutter segmenting the membrane into smaller parts, and then I'll go and peel it with a forceps from the disc. But again, there's a broad adhesion over the superior arcade. So I'll continue with the scissor until I'm successful to taking it out in just one piece without causing any breaks, which is a surprise for me
Yeah.
too.
This is a very big challenge. Yes.
Yes, usually it causes breaks. So the next challenge is getting this cartilaginous membrane outside the eye. So I thought to myself, okay, I'll go with the cutter, high vacuum, but nothing. It can be taken out of the eye with a cut rate of 5,500. So now I go up with the vacuum and go down with the cutter until 1,000 cut per minute, but still it's not budging, and I go down to 500 cuts per minute just to be able to consume this membrane and take it out. So, do you believe in 25 gauge would eat this up?
No.
That's the problem in such cases. That 25 gauge can be helpful in dissecting, but when you want to remove such a big chunk, you have to resort to a larger gauge to remove it. So here it's a 450 vacuum, 500 cut rate. Just I was able after around 2 or 3 minutes trying to eat up this membrane.
But it went very nicely.
Yeah. What's your next step with this subretinal fluid, large subretinal fluid? Would you leave it? Would you?
Yeah, if no tears, I will leave it and I will add laser in the attached part if there is.
Okay. No, I decided to do a draining retinotomy here because this patient was from abroad and he needed to travel early with a flight, so I couldn't leave gas. I left him on silicone oil, drained the fluid, and did a PRP. So when would you do this? If the patient was one-eyed, would you consider doing this to put silicone
No,
oil?
I will not do a retinotomy in such a patient, especially in diabetics with this large NVD present. And if I will do a retinotomy, I will not do it near the macula in such place. And if he is traveling, I will just add the silicone oil and he can travel. And after 2 to 3 months, and because preferably if diabetic patients went well, you should remove the silicone as early as possible because the subretinal, the subsilicone fibrosis that occur in diabetic patients is very aggressive and it's very adherent. So if you tend to leave the silicone for 5 to 6 months, probably you can remove the silicone, but these attachments
It's
are
very
very
difficult
hard. Yeah, and it may be compromised even this nicely cleaned macula, and you may find that there are more proliferation over the
Yes.
macula and you cannot remove it.
I know this is the scientifically sound opinion, but for me, leaving such a large amount of subretinal fluid, it would hinder me completing the PRP efficiently The patient is traveling. I want to fix the anatomy as much as possible when the patient is
If you
under
inject,
my
if you
hands.
if you just inject at the end of the surgery to control these PDR components like the MVD or MVE, and leaving this because the subretinal fluid is due to the traction that was present.
Yes, yes, I
There
know.
is no rigmatogenous
Yeah,
element here.
exactly.
So I think it will relieve within 1 week this subretinal.
But you've seen cases with tractional retinal detachment. There is a poor choroidal perfusion, and there is subretinal fluid that stays for months after surgery. Maybe years. So that's why I was more inclined to try and to remove as much as possible of the subretinal fluid and leave a tamponade, longer term tamponade, since he's traveling. And maybe after 3 months, I would call him back to remove the silicone oil. The patient presented to me after 2 days with subsilicone hemorrhage. Over the it was a little bit dense, but just after a few days it subsided a lot, and the vision was around 260. I'm following up this patient and didn't see what happened, but I know what you're talking about, that the subsilicone perforations are very nasty, and they can end the case for
Yes.
me. Okay, so you're still against the preoperative injection in this case, right?
If the vascular component in this, I didn't see
Yes,
how
I
it
know
was.
it's very subjective to
Yes.
decide, and you just see the patient and you take the decision. But and there's no rule if to when to inject and when not to inject. But in such a broad adhesion, I know you're afraid of the contraction and the.
No, I don't. My issue is not the crunch effect. My issue is when you inject such a vascular component. If it is not that vascular, it turns the membrane into from a fragile, malleable membrane that you can even dissect this membrane or segment it into this hard, cartilaginous, fibrous, very hard component, even to eat with the cutter. And this may even make your undermining or the dissection of the membrane challenging more when the attachment is much more adherent when you turning this gelatinous membrane into a harder one. So this is my issue, because the dissection is you're aiming such a surgery without inducing any iatrogenic breaks. So I'm not afraid of the crunching, because you are going to operate this patient
In
within
2 3 days, yeah. Okay, so it's always different opinions,
especially in
individuals.
diabetics.
Yeah,
Yes.
yeah. Okay, thank you very much for watching. Hope you enjoyed this episode, and stay tuned for the next one. Thank you.
Thank you.